With everyone. And yeah, I just wanted to take you through some work we're doing in Indonesia. We call this the SPHERES Project, which stands for Systematic Public Health Empowerment Research and Education Sites. And I just want to walk you through what that's about and hopefully have some useful discussion on this. Um, so let's see here. Yeah, just a bit about, OCRU. So basically, I lead the Community Health Research Unit at the Oxford University Clinical Research Unit here in Indonesia. And our main focus of the Community Health Research Unit here is to try to define specific pathways and interventions at the community level and understand how those interact with other behavioral and biomedical factors. So digital health, really in the context of health systems, is an important part of the work that we're engaged with. And I want to give a sort of an acknowledgement here to Summit Institute for Development, which is a local organization that's been working on digital health for a long time here in Indonesia. And I'm going to show you some of the work and how we're working together with them. And also want to highlight this organization, which is Genomic Solidaritas Indonesia, which is actually a high throughput molecular diagnostics and sequencing organization that we helped to launch during the pandemic. And I'll show you how this really integrates with some of the work that we are doing now. So both Summit Institute and GSI Lab are core partners in the Spheres initiative. So Indonesia at a glance, for those of you maybe who are not that familiar with Indonesia, it is the fourth most populous country in the world. I think we often forget that. It's sort of an intermediate to high income country. They've recently been reclassified, but there's of course quite a bit of heterogeneity in the country with respect to income level and poverty. And this is just an overview here of some of the primary healthcare issues, specifically for maternal health and neonatal health. These are some of the challenges faced in Indonesia. And particularly, we see a lot of challenges in health system development let me just put my laser here, uh, in eastern Indonesia around here. The most populated parts of Indonesia are here, the island of Java and Sumatra. In fact, I think somewhere around 70% of the population of Indonesia, or perhaps more, lives on this island of Java. Here's uh, Bali. Many of you might be familiar with that because many times when people hear about Indonesia, they think about Bali. But in fact, Indonesia is a lot more than that. Um, so as a starting point for this talk, I want to take you back to a study we did here in Indonesia a long, long time ago, about 25 years ago. This was a large-scale randomized controlled trial of nutritional supplementation in pregnancy. And it showed that a complete vitamin supplement in pregnancy actually reduces deaths by around 18% in children, 38% reduction in deaths if the mother had been anemic during the pregnancy. Now, the reason I'm sharing this with you is because this trial was actually integrated in with the health system in Indonesia. And in order to do that, we needed to um, enhance the quality of primary health care delivery to support the embedding of this double-blind RCT within the health system itself. So one of the things that we did, we got authorization to recompete these positions in the Indonesian health system of community health promoters. So every village in Indonesia normally had a community health promoter, but we wanted to open those positions up to uh, hire additional ones or to make sure the ones that were hired were of high quality. So we got permission to do that, and we actually hired around, I can't recall, maybe around 500 of these community health promoters. And because of the way we recruited them and deployed them, we were able to assess their quality. So interestingly enough, during the summit, so I showed you this here, where overall, the deaths due to the nutrient supplementation in the double-blind randomized trial was about an 18% reduction in death. But in fact, deaths overall in communities went down around 30 to 40%. So these were the same infant deaths. And it turned out the reason for that was these community health promoters. So overall, they were going around promoting health. And we could do this calculation because we had assessed, carefully what their performance was. And we could see that, in fact, if you were a good quality community health promoter, death in your community, infant death, went down by around 35% or so. If you were average, around 20% reduction in death. If you were of poor quality, then really there was no impact at all. There would only be the impact of the nutritional supplement, but no added value. So we realized that actually somehow enhancing the quality of care delivery of these frontline health workers was very important. And we had utilized digital technology during that trial, but it was a paper-based system, sort of where we would print out assignments for health workers, ask them to go there, track that and so forth. So after the summit, we realized that we needed to create sort of a more formalized digital tool, system of apps. And at that time, in 2012, I think, or so, there wasn't actually a open source digital technology system to bridge the information gap from the community health center to the community. So we developed this system that we called Open SRP, Open Smart Register Platform. This was a partnership between the World Health Organization, ONA Systems in Kenya, IRD in Pakistan, and Power in Bangladesh, and the Summit Institute for Development in Indonesia. So we were able to develop this series of apps, and these apps were able to actually exchange information between them. So in that process, we were able to transform the frontline primary healthcare system in these sites where we deployed the apps. We were able to transform that system from what we called a provider-centered one, where these different members of the family might go to different facilities or persons, either a community health center, village health center, village extension clinic, early childhood development center, all these different things providing centers or activities providing primary health care. We could transform them into this sort of person-centered healthcare, because wherever they went to a particular provider, their health care they received elsewhere would be available to be seen, so that new provider would know what they should provide. So you could fill gaps in care from doing this. So what we observed in this deployment, that in fact, this team-based care could have a very substantial effect. And here we see ANC attendance went up 50% to more than 70%. Complete ANC, basically doubled, although still, frankly, should be a lot higher. Postnatal care, which they were not doing at all, they started to do that. And interestingly, there was an impact on survival, mostly child survival, a very substantial impact, in fact. So, in fact, this work, this sort of team-based, digitally coordinated healthcare, was recognized by the World Health Organization as one of the top 10 innovations in primary healthcare several years ago. And in fact, it had a very interesting influence on the World Health Organization, because they realized that this app, this core app that we had developed, had actually been the implementation of the WHO basic antenatal care guidelines for a positive pregnancy experience. So they realized there had been a digital adaptation of that. So they decided that, in fact, this could be a use case for how WHO guidelines could be digitalized. So creating this digital adaptation kit, with the first use case being this work that we had done here in Indonesia on Open SRP. So we're able to do that, create this digital adaptation kit. Then we created this core reference software, which was essentially an adaptation of this original software we had developed. And then the WHO decided that interoperability of data was very important, just like we had created, but they wanted a formalized standard for that interoperability that all countries could deploy. And it turned out this organization called HL7, Health Level 7, had created a standard for data interoperability called the FHIR standard. And so WHO wanted to promote this. If you go to the WHO website now, you can see there's this progressive layers of smart guidelines for deployment of digital health to support a particular delivery channel for primary health care. First, you come up with, of course, the health policy, a narrative guideline. Then you create this digital adaptation kit. And then you come up with what are called machine readable recommendations, which are essentially how the process you're trying to deliver in primary healthcare can be ported to the FHIR standard. And then an actual reference software. And then this last one is this precision health model where we're using that data to actually further improve healthcare delivery. So this is FHIR, as I mentioned, Fast Healthcare Interoperability Resources. And this is a standard, really. It's a health information exchange standard where all data is standardized to be stored with a common, titles of different health concepts you're collecting. For instance, hemoglobin, everyone would use the same definition of hemoglobin, the same the name of hemoglobin, HB, or whatever it actually is in the database. So all the databases would be fully interoperable. In addition to that, there's a semantic and a syntactic interoperability component of this that is standardized so that, in fact, you can exchange a packet of information, let's say maternal hemoglobin. You can exchange that packet with another app or a server, and that information will keep its same context. So, for instance, this was done for the first ANC encounter on such and such date for such and such individual, and so forth. So that hemoglobin is always linked together with all the other information that is required to interpret that. So that's why it's called Fast Healthcare Interoperability Resources. That packet that's exchangeable, that is called a resource. So again, that's why it's called Fast Healthcare Interoperability Resources. Now, this is important because normally when you have information, if you have a health, like a use case, and you might create an app for that or some way, some kind of a digital tool or platform. So that's a siloed system for that specific project. So often when we do health research, if you're doing like an RCT, you might create a information platform for that, and that would sort of fall in this category. So that's a siloed system. Then you might have an integrated system where you have several different apps that might be able to communicate with each other in some way. And then you have this sort of more mature system, which requires interoperability standards. So this is an exchange system. So this is really to support health sector goals where you have multiple different apps, multiple different systems that need to interact. You have to eventually port towards some sort of a interoperability information system. So these standards on FHIR enable that interoperability. So it's not just integration, it's full interoperability. So integration is something like you might have multiple systems here on the left, and they're talking to each other, but you've created some sort of adapter, right? So this circle can talk to this one through this adapter, but for this circle to talk to this one down here, you need another adapter. So you see this sort of, combinatorial explosion if you don't use standards in some way. But with the standards, you're able to obtain this full interoperability. So let me just skip this. So what we were able to do with a grant from Gates Foundation and with the Summit Institute for Development, we were able to work with a district, actually several districts in Indonesia, to create what was called a digitally enabled district data flow. And this essentially was taking all the apps here that a health center would normally deploy, whether it was for antenatal care, child weight growth, vaccinations, whatever that was, and to push that data using the FHIR standard into a FHIR server at the level of the district. We also deploy these OpenSRP apps, which were refactored to be able to push data into FHIR directly out of the app. So you didn't have to do the second sort of adaptational step that you had to do with the older apps. In any case, all the data then ended up on this server at the district level, and this data would then be submitted to this system that the MOH had created here called Satu Sehat, which was the plan of the government that all health data should be streamed up to this single information system through the MOH. And in fact, most countries are doing something akin to that now based on the FHIR standard, because the FHIR standard use of that has been a mandate from the World Health Organization. So once these data are available at the level of the district, in fact, you can use that to power dashboards, command centers, send out text messages, all sorts of things that you can do when all these data are pooled together and integrated and can be analyzed in real time through script-based systems on servers. And so we had deployed that with the Summit Institute for Development. And you can see pretty quick gains from doing that. This is just a few things: hepatitis B surface antigen test, going up. This is a PMTCT that was basically doubles. Sorry, it's so squeezed down here at the bottom because there are only a few of the pregnant women who were eligible for that based on, of course, being HIV positive. But this is interesting, glucose testing, which they were really not doing. Once there's just open accountability for it, it really went up tremendously. And of course, hemoglobin, which they were doing, that's going up. So that was very interesting. We discovered that. But in fact, there were other things that were not changing as much as we would hope they were, particularly related to general quality of healthcare worker performance. So I want to bring you back to this idea that a lot of people probably had seen, those of you who are interested in digital health or digital health transformation. And you can see, like in the middle here, services and applications, standards, interoperability, and digital. This is what most people think of when they're doing digital transformation. But in fact, these other aspects, we discovered and have to promote more, that these things are actually of equal or more importance than the information technology side of it. And so we realized that to really get full digital transformation, you had to do more than just information technology. So this is really the origin of the Spheres idea that apps and technology are necessary but not sufficient to go digital, and that digital transformation really needs more of a change of culture and active use of data. So the goal was to create a framework that would transform a digitally enabled district to really a smart district able to actively use that information. So this was the birth of Spheres, which is a systematic public health empowerment, again, empowerment with information, research, because now you can use that information to create discovery and education, because now you can train actually public health professionals in public health practice, and you can see if they're able to do the management of the health of the population. So this is the original digitally enabled district concept here that I'm sort of circling here, right? And then we put a wrapper on that for much higher and intense use of information, where in fact we create what are called public health data theaters, where all this data streams into, and heads of community health centers, heads of district health office, members from the community. They look at these data once a month and they write a prescription for action. So this is the intervention, the spheres intervention. They write the prescription for action for a month. Then they come back and they look at that and they say, well, is there any difference that's occurred in these communities by that prescription? They say, well, there's no difference. Maybe we'll give it another, 2 months to see if there's any difference. If there's not, they say, well, that prescription for action doesn't work, and we have to do something else. So it's this sort of dynamic intervention where you're doing sort of precision public health at the level of each community and designing that and re-prescribing a new action on a monthly basis. So that's the intervention. That's the spheres intervention, essentially. And we, teach them, again, how to look at data, how to interpret it, how to create a prescription for action, and how to create a debate around what should be done. So for this debate, we invented this other intellectual combat sport that we call Shinjitsu. And it basically teaches people to take a point of a perspective on something, an interpretation of information, present that, and then an opposing person does the same. So they actually have a face-to-face argument or discussion about this, and a group of judges then gives them scores, and you see, who has the better argument. And of course, there's a whole process of going through and deciding what action should be done. So the goal here is to encourage open discussion about these sorts of things. So Spheres is actually about creating next generation primary health care. You're able to empower health workers and clients with data for action, capture all basic clinical outcomes from community to facility, including community health centers, including hospitals. And you can apply analytics and AI to discover disease trends, et cetera, and enable training in data-driven public health practice. So really, there's these core innovations here. So let me see. Let me just come back to this. So this is why is Spheres transformative? So you get this triple synergy, empowerment of all public health services and programs for rapid transformation of health impact, and education of public health professionals. So this is important because right now, globally, if you trained as a doctor, you are trained in the theory of being a doctor, all the key biology, physiology, et cetera, and you actually practice with patients, often in a teaching hospital of some sort. In public health, there is no such equivalent. We basically train people in the classroom and we say, go out and be a public health practitioner, which is, crazy, but that is the norm. So the reason that exists is because there's no equivalent of a teaching hospital for public health. So Spheres enables you to have a teaching community, a district-wide teaching community that is like a training hospital for a doctor, but is for a public health practitioner. And the third sort of transformational thing here is that you can do now large-scale randomized controlled trials in a community if the outcomes are in fact normally captured through the routine primary healthcare system. So you would do a randomization, and this information for the outcomes would be collected. So you can generate large-scale RCTs in a short amount of time. So this knowledge creation is there. And in fact, Spheres itself is in fact a large-scale randomized controlled trial. It's a step wedge RCT, deploying that intervention, as I mentioned to you, approximately 4 million persons, the intervention area over a 2-year period with direct enrollment of target beneficiaries around 800,000 individuals. And this is what we're the power calculation for Spheres as a trial. We intend to enhance coverage of services, overall primary healthcare services by at least 30%, reduce care gaps by 75%, and improve health outcomes by at least 25% by reducing maternal and neonatal deaths, enhancing tuberculosis detection and treatment, and control of hypertension and diabetes. We feel these are conservative. There might actually be bigger effects, as I mentioned before, that we had seen previously, but then 80% of monthly actions based on review of information and increase in client satisfaction. So there's a couple of other things that we can deploy in this context that I just want to highlight. So, for example, we had done a validation of this phone-based blood pressure tool. So, in fact, with these apps, you can deploy this kind of a tool, which essentially, this particular thing is called BP, optical blood pressure assessment. You put your finger on the camera of the phone and the flash, you launch the app, and in around 30 seconds or so, it gives you your blood pressure. And we've done a validation of this here amongst pregnant women and others, and children as well, shown that this works successfully. So again, this is something deploying within the spheres context, can be done. And you can also do another thing with spheres, which is that because RDTs are routinely used in primary healthcare, if you actually capture all those RDTs and do additional analysis on them through, again, these apps that are deployed, you can get more information. For instance, the density of a line on RDT, that can often give additional quantitative information. We've also done other work where we actually do genomics on these RDTs. You can do a pathogen genomics on RDTs, interestingly enough, on SARS-CoV-2, dengue, malaria as well. So this is another key thing that you can use if the spheres infrastructure exists. And lastly, we've been exploring this genomics, essentially creating polygenic risk scores during pregnancy or for the child, and then looking at those, and then you can directly push the augmented or changed care plan for any particular individual through the information system that is spheres and lead to changes in care delivery. So you can integrate the behavioral and the genomics aspects to optimize a care plan for a individual. So these are the implications for large-scale community-based trials and programs through the spheres platform. I gave you some examples of that: mobile diagnostics, OptiBP for hypertension, host pathogen genomics. Right now, a doctoral student working with me, Edward Satanto, he's using the spheres platform to, in fact, see how you can potentiate the use of tenofovir during pregnancy to reduce vertical transmission of hepatitis B. Seeing how that intervention, which is a known intervention, can be more successfully implemented at scale through integration with this. So last, I want to share with you this tips for success from this movie, Ratatouille. For those of you who have not seen it, I recommend it. But there's a quote in there from one of the cooks that says, "You must be imaginative, strong-hearted. You must try things that may not work. You must not let anyone define your limits because of where you come from." So looking forward to fruitful discussion about this, and thanks so much for your attention.
Great. Thank you so much, Anu. Yes, please, everyone, put any questions you have in the chat, and we'll turn it over to Professor Louise Thwaites, and then we'll have time for more questions and answer at the end. So over to you, Louise.
Okay. Can you see the slides full screen, everyone?
Yes.
Perfect. Okay. Hi, everyone. Nice to see so many familiar names and not so much faces, but names. Good afternoon, good morning to everybody. My name, for those of you I don't know, is Louise Thwaites. I'm a clinician researcher, and I'm based at Oxford University Clinical Research Unit in Vietnam, so near to Anu and similar but different challenges very often in our healthcare sector. I've been based, living and working for a long time in Ho Chi Minh City in Vietnam, but Vietnam has two HIGHQ units, one in the north in Hanoi and one in Ho Chi Minh City. The population of Vietnam is a little bit smaller than Indonesia, but nevertheless still significantly bigger than the UK. And just to remind you why we're interested really in digital health and these innovations is the huge demand the healthcare system is under. We're spending in Vietnam about £150 per person per year. That equates, I think, to about £5,000 in the UK. And yet we're expected to deliver ever increasingly complex care. My background is as a critical care physician, so a lot of what I'm going to be talking about is hopefully going to complement Anu. I'm going to be talking about hospital, patients and systems rather than community, also mainly adults. So when we're looking at that healthcare expenditure, also remember who's paying. These graphs are showing the expenditure for the UK and Vietnam. The blue line is government spending, and the red line is out of pocket. And you can see a big difference with in Vietnam, about 50-50 over recent years. 50% of healthcare spending is coming from patients and their families. And that has big implications. We can, in terms of who's paying, and particularly how the poorest and most vulnerable communities are treated. So not surprisingly, the Vietnamese government is trying to improve care for all patients and looking particularly around digital healthcare technologies and artificial AI to try and help that. In Vietnam, compared to other countries in the region, there are less doctors per head of population than comparable countries. So that places a big strain on resources. Particularly underdeveloped is general practice and primary care, although there is a very, very good network of community, very basic level clinics at the commune or ward level. Counteracting that, there's very relatively well-developed digital infrastructure in terms of high mobile phone usage, digital literacy, high internet penetration rates. And as I said, the government is very keen and supportive of innovations in the digital healthcare sector. And indeed, Ho Chi Minh City, which is where I'm based, has been selected as the future digital healthcare hub. Ideally for the whole region. And the pictures are on the right with ongoing work we are doing at HIGHQ with the Department of Health and the UK government trying to support that digital healthcare transformation in Ho Chi Minh City. And indeed, I suspect some of you on the call have helped with that ongoing work. So where are we in terms of hospitals and digital technology? Well, this is work by Dirk, one of our team, who has been a research assistant with us, and he has worked with Chris Payton looking at digital healthcare readiness of Vietnamese hospitals. The Vietnamese government have actually published a digital maturity structure for Vietnamese hospitals. And so it's possible along these various subtypes, subgroups, to look at the readiness and the maturity of hospitals. And this is a survey of 5 hospitals. Most of these were tertiary hospitals, so higher level hospitals, but also a district hospital in there. And you can probably see Hospital A has reached 100% maturity, so it's doing very well along all areas in digital health as the government sees it. So good infrastructure in terms of IT, computer stations, server capacity, etc. But also hospital information systems, which are generally to do with booking appointments, payment, finance, accounts, radiology, laboratory information systems. And probably you can see the blue and the red lines are in the area of electronic medical records, so are where most hospitals are failing. And we think, we've looked at this before, but there are many barriers to introducing digital healthcare technology for patient care as well as just administration. lack of staff generally, but also lack of adequately trained staff and staff confident in the use of digital technologies, a lack of basic equipment, and that's not just computers and workstations, but compatible monitoring systems. And as I've highlighted, particularly electronic healthcare records. Most digital health management systems and indeed, as Anu has just shown us really well, if you've got good electronic medical record data, you can layer on many useful interventions. But if you're largely paper-based, then that is impossible. Of course, the context these systems are working in is really important. There have been many studies in different low middle income countries highlighting the particular demands in terms of healthcare environments, power cuts, internet connectivity, which also are impediments to introducing things. So I'm going to just spend really now some time just giving you some examples of some of the things we have been doing in Vietnam and with collaborators in Oxford to try and address these problems and to make sure that a country like Vietnam is able to take advantage of the rapidly advancing digital healthcare landscape. I said I'm an intensive care doctor, and just to remind us, again, about what's out there already. What could we be using in critical care to improve patients? And most commonly looked at are ways that we can use AI and digital healthcare electronic medical record data to predict patients who are likely to deteriorate, get worse, and so that we can intervene early. And this is a recent review just highlighting what's already out there. These are the studies from critical care around the world. And it's important to see that very few of these have actually been properly validated, even those in high-income countries. So the ones on, if you look on the left, the yellow highlighted bar is the ones who, the AI scoring systems which have been validated, and the black are those which haven't. And that probably, knowing the background of many of you here, won't surprise you. I think also slightly alarming for those of us working anywhere in healthcare is the data which these systems are based on. And the majority of systems are developed and validated on publicly available healthcare sets from the US, not from other countries. And that's what's being shown on the right. And that obviously presents us with problems wherever you're going to implement AI systems which have been developed elsewhere. I'm going to show you a little bit about this now, and also some of the strategies we've been working on to overcome this. So through this collaboration with Professor David Clifton and his team in Oxford at the Institute of Biomechanical Engineering, we've been working on two different strategies really to allow us to improve care of critically ill patients. So moving on from that slide I've just shown you, what can we do to predict patients who are becoming worse in ICU? And can we just bring models over from countries like the UK? And this is an example of what we did and what can go wrong, but also some strategies to improve it. So this is an example using a model that was developed in the UK for COVID, predicting COVID-19 likely diagnosis when patients were admitted to accident and emergency departments across several sites in the UK, but a very large data set developed this, about 40,000 patients. This was validated externally, and it's actually tested in real time to show that it did improve sensitivity compared to lateral flow tests. And actually, using these routinely available data that the AI system was based on, linked to electronic health records, you could do that actually faster than doing a lateral flow test or a PCR test. So the graph on the right is showing what's happened when we did that with data from Vietnam. So we have two hospitals, NHTD and HTD. These are hospitals, large tertiary hospitals, admitting large numbers of patients with infectious diseases in North and South Vietnam. And circled is what happens when you apply just the exact model that was available in the UK in Vietnam. And you can see, particularly in NHTD, we're only just over 0.5 for the area under the curve analysis, which means it's pretty much not better than guessing. But then what we wanted to do was try and look at, can we improve this? So the first thing we did is that we improved the data that was already available in the model. So not surprisingly, in high-income countries, there was already more routinely available healthcare data than there were in Vietnam. And these were simple blood tests that were available on admission in the UK. They weren't available in Vietnam. So firstly, by using some imputational techniques and using averages of data from elsewhere and retraining, we were able to improve the performance of our model. And that's quite nice and quite interesting just in itself, that you don't have to throw out missing data. We just added 6 different variables here and improved the score. But next, what we did was something called transfer learning, and that's really utilizing the power of AI. So using all the knowledge that's already available from a big data set like the UK, but then fine-tuning it based on the Vietnam data. And on the right-hand side, I hope you can see that the performance of the model massively increased by doing that. It increased even more by doing it with the augmented data set, and also the performance was better than just training a model with locally available data alone. So really showing that I think this partnership, using a good model that's been built and validated somewhere else, it can be adapted, but it needs to be adapted to be efficient. The other thing I'm just going to show you along with this work is what we also did to try and make sure we were looking at fairness of models. So I think those of you who listen to AI, there's a lot of talk about fairness and inequality and the potential ways that we might be trying to deal with this. So what we did here is we just used the data from our hospital for tropical diseases, which was patient for about 2,000 patients worth of data, combined with 40,000 from the UK. And we trained a model using the top line are these results of that model, and showing an area under the curve of that, a pretty good performance. When we put all that data together, we got pretty good performance. But on the right-hand side, the EO of the TP, FP, true and false positives, are the way when we look at fairness of the model. How was it handling particular subgroups of patient data? And for this, we just used data from Vietnam versus the individual sites. And the key for looking at these results is the higher the number there, the worse it is, the opposite area under the curve. So it wasn't working so well. But if we use some other strategies in terms of adjusting these models, then again, you can improve the performance of models. So we tried to work out why wasn't it working so well in Vietnam. Most of the variables were blood tests, and you think, a hemoglobin is the same, a white count is the same. But when we looked at it, specifically the respiratory rate and the temperature were different in Vietnam compared to the UK data. It probably won't surprise you if you worked in low middle income country settings. Very often the respiratory rate is just estimated by very, very busy staff. And similarly, the temperature is measured much more approximately. We don't have nice temperature ways of measuring it. So perhaps not surprisingly, these were areas for variation. So we then did 2 different models. We did a simple neural network model with all the data, and then we did the same model and we removed the respiratory rate and temperature data, and that improved the fairness, but it was a trade-off of the accuracy of the model. And again, perhaps not surprising, because if you're looking at patients who might have COVID and severe COVID, you might expect temperature differences and differences in respiratory rate to be quite important predictors. So the bottom line is showing what we did using a different AI technique that enabled us to retain those data, something called reinforcement learning, and at the same time to teach the model that these data were important and essentially reward it for good performance. And what you can see there is that you can actually improve the performance of the model and also improve the fairness of the model. So I guess summing up there, what we're trying to say is that models can be moved, but they do need to be contextualized, and that's very important. Now, I am going to talk about wearables a little bit. So those are models built on essentially normally available healthcare data. And in our setting, they come from a monitor like this, a bedside monitor, where you can see all those lovely waveforms. But we simply collect some of those summary data, and then they're entered into electronic health records, which then make the AI models. If you're somewhere with a few better, nicer facilities, you'll have a nicer looking monitor, but probably similar data will be going automatically into your electronic healthcare record. But what you can also get if you've got one of these nicer monitors is you can take out that whole waveform itself. And that's important to know because the waveform contains a huge amount of physiological information. The reason we're interested in the heart rate and the blood pressure is because it tells us about how the body is responding. But there are a lot more subtle things within these waveforms that can do that. And by not analysing those, potentially we're missing a lot of opportunity to really understand how individuals respond to infection. And so it's great if you've got a nice monitor like this, and I know in Oxford there are some nice monitors, and you can obtain these data and you can make some really fantastic AI models because you need that level of AI really to be able to interrogate these complicated waveforms. But in our setting, these are very expensive. These monitors cost about $16,000 each. So we've been working using lower cost devices, wearable devices, to get similar data. So this is an example. This is a pulse oximeter, actually, I think originally developed as a DPhil project and then spun out and commercialized, but it's a low cost pulse oximeter. It connects via Bluetooth to a phone, and then you can take data directly from that phone or tablet or to a computer. Or on the left-hand side of the screen, we partnered with a local company who make a platform that can connect multiple devices for us. And we can use that simply as a way of remotely monitoring a lot of patients, which we did in COVID. You can see we put some little traffic lights around orange and red, or no colors to highlight where some of the vital sign observations were falling out of the normal range to alert some of the nurses. But what we can also do with these data is we can actually take those whole waveforms and then we can start to analyze those in a much more complex way. Part of the skill of doing this is by knowing how to clean the data. There is a reason these wearables are low cost and you lose a lot of the signal processing and the cleaning, so you get quite messy, noisy data. So there's a whole layer of signal processing and cleaning of data that needs to happen. But when you do that, you can end up with data that's comparable to from those very high quality, expensive monitors. So we've been doing this in many diseases now in Vietnam, and this is an example of the work we've been doing in patients with tetanus. Tetanus is a big problem in Vietnam. Patients come into hospital. They're often quite mild at presentation, but can rapidly become more severe. And predicting which patients will become more severe is very important in terms of planning care, making sure patients have the right treatment early enough, and that senior staff are on hand to deal with complications. So in this project, we have been collecting pulse oximetry data from a wearable device, but also, if you can see there, there's a wearable patch and ECG device on that patient's chest. And those data essentially are streamed, and then we can analyze the waveform. And on the right is an example of some of the analysis we've done of ECG data. You can extract specific features from those ECGs, or you can also do more complex analysis, essentially turning them into images and using image type AI to analyze those. And a particular strength of our team and the collaborators involved is that we have skills in the long-term time sequence data. So seeing how these individual patients' data change over time. And we've published several papers now showing how this can improve classification of tetanus disease, but also in patients with sepsis, how these time changes over the first 24 hours can be predictive of eventual outcome. So that's involved actually a huge amount of work and technical expertise. But we're now at the step of, okay, we've got some AI algorithms that we think predict the outcome, but how do these really work in real time? And this is where we step up probably exponentially in complexity, because of course we're now introducing these systems in real patients in real life. Data is flowing through in real time, and the AI is making continuous predictions on this. This is a project now running in patients with tetanus in the ICU at the Hospital for Tropical Diseases. And I think it's the world's first trial of such an AI system in real time that's running off the waveform data from pulse oximeters. It's running through a local computer, which runs the AI algorithm. And if that predicts whether a patient's deteriorating, then that's sending an alert to a study doctor who will then check the patient to see if they do appear to be deteriorating. And the bottom right is some of our study team and our very first patient who was in that study. But of course, there's going to be a lot more to it than that. Even if this proves to be a superbly accurate model, then we still need to make sure it works in practice. So alongside this technical work, we have been doing a lot of work with staff, with patients, to try and understand and make sure that our systems are going to fit well into the healthcare systems. We were afforded the opportunity to rapidly introduce wearable monitoring during the pandemic, and we made a lot of very important observations there. On top of that, we've been doing some formal qualitative work and ethnography to understand more about patient staff workflows and views. And it won't surprise people, I suspect, to know that it's very important that such technologies are going to fit into workflows that staff are already doing. We found some very interesting things when we compared systems with Oxford and Vietnam in the way that the nurses work and what was important to them. And several features that have been very useful in Oxford, for example, the monitors, the big monitors saying when devices were running out of batteries, but actually these were absolutely useless in Vietnam because the nurses were so busy, they didn't have time to respond to individual alarms. And if they were going to change devices and batteries and charge these wearable devices, they were going to do it all when it fitted with their routine. Familiarity with old technology is very important, and Anne, who I can see is on the call, and Jake have done a really nice piece of work where they've looked at the design and worked with staff to see what would be the best design, what would they really like, and maybe again, unsurprisingly, what they really liked is something that more or less looked like what they had already. And then finally, it's really important to make sure we're understanding patients' experiences of this, particularly in critical care. That can be very hard to get. And actually, most of the work on wearable devices that's been published completely ignores patient experiences and acceptability. But of course, we're expecting patients to wear these devices for long periods of time. We've noticed during COVID, again, a rapid change in patients' understanding and awareness about the meanings of some of the data. So, for example, when we started in COVID with wearable pulse oximeters, patients felt very reassured. They could see this thing called SpO2, and they weren't particularly worried about it. And generally, at that point, the patients we were monitoring were pretty well. By the end of the pandemic, though, patients really understood what this SpO2 number was. They were very worried if it changed or deviated, and actually seeing the data caused quite a lot of anxiety. So we actually ended up removing the bedside phones out of the way of the patients in many of the settings to reduce that anxiety that they were experiencing. And we've just come back today from training. We're doing a public engagement project with Vietnamese staff and patients and community members to really explore some of these issues further. So I think we are really at the end of the talk now. I hope I've shown, just reminded us that contextual understanding is absolutely essential and things must be developed, but development needs to be ongoing in collaboration with end users because the needs also change. And finally, when we're looking at wearables and monitors, I haven't gone into this in any detail here, but I think this is Jake's phrase, a nurse is not an alarm. What we don't want to do is remove nurses from the bedside. What we want to do with all of these technologies is free up medical staff so that they're able to do things which are really much more important to them and to patients, so that we can really improve quality of care and really capitalize on what medical staff can do. So I think that's the end of my talk. Huge number of people. I probably missed people off here. Thank you so much. And I think we're ready for questions.
Great. Thank you so much, Louise.